evening. Good to have you with us in the 9 p.m. edition of the Urban Debate. Viewers, tonight we are going to talk about key issues linked to COVID, where there is much confusion even now. I still see so many people running around asking for help and leads and support to source remdesivir, to get plasma to help somebody on an extremely large scale. This is still going on in our country. Every day we get bombarded with queries on the correct gap between two vaccination doses, whether specifically for Covishield but even for Covaxin. And what if you've been infected? Then how long should you wait? There has been change in policies that's adding further to the confusion for people and raising many doubts. There are many of those who are now planning to travel abroad for studies or to be with their family members, with their children. And they don't know what to do as far as the vaccine is concerned because of the changing gap durations. And whether or not a vaccine like Covaxin, which is not yet officially recognized globally by WHO, will it even be taken seriously by many of the other countries? Several people constantly ask us questions about the mucormycosis, the black fungus, and how concerned should they be? Are there medicines, treatment, drugs available for it? We are flooded every single day with these kind of queries. And I am no expert, but I do have a platform where I can get the experts, and I do that frequently. And we take your queries, we take your doubts and try to address them. So tonight again, viewers, we're going to do that. We've opened up our phone lines. They're open for you. If you have any queries regarding any of the life-saving drugs for COVID, any of the treatment therapies and processes that are being followed, about vaccination, then do call us and our experts will try and help you as much as they can. Meanwhile, they'll take some of my doubts and my queries and my questions. Let me say good evening to the panelists who are joining us right now. Dr. Anand Ban, researcher for global health, bioethics and health policy. Dr. Rakesh Mishra, former CCMB director, joins us this evening. Dr. Chandrakant Lehria, an expert on vaccine and public policy in health systems, who joins us this evening as well. And we also have Dr. Aparna Mukherjee, senior scientist for clinical trials and health systems in ICMR. And Dr. Mukherjee, I want to start off with you because I want to start with plasma therapy. And today, we were told that plasma therapy has been dropped from the list of, advisory COVID management and treatments. That's been completely removed from their basis, the studies and data that we have. Can you help our viewers understand this? Because a lot of them are still taking calls for plasma treatment by their medical experts extremely seriously.
Right. So, plasma therapy was started off as there was some biological plausibility to it because it has antibodies which can neutralize the virus. And so this has been used in other infectious diseases as well. So this was tried out with the beginning of the pandemic, and across the world, many patients have been receiving plasma. But as the pandemic has progressed and we have more evidence with us now, and we have been able to do proper large studies, evidence has been garnered that administering plasma, even high titer plasma, is not actually showing any therapeutic benefit in terms of reduction in the progression to severe disease or reduction in mortality. And so that is why all these evidences were reviewed, and they were pooled, and meta-analysis were also reviewed, and then a decision was taken that plasma as it is currently being used is not having any therapeutic benefit, does not seem to have therapeutic benefit depending upon the current evidence, and so it was removed from the guidelines.
So on no kind of cases you're saying there is any evidence that it helps, whether they are mild cases or moderate or severe conditions. Under no conditions do we right now at this moment have any credible data that suggests that plasma is helpful in getting rid of the infection or even stopping further spread. Would that be correct?
Plasma primarily is being used as an antiviral. So we are reiterating that using it in very sick patients, severely ill, critically ill, ventilated, or even on non-invasive ventilation, it is unlikely to have any benefit. That is what all the studies have been showing. Some school of thought is there that it might have some effect in a very niche niche category of patients where they are in very early moderate stage. Within say 3 or 4 days they have started deteriorating and you have very high plasma titers and the patient themselves have not developed antibodies. So in such a scenario, it still might help, but then that's a very restricted scenario, and even there, we do not have concrete proof that it is going to help.
Okay. Let me also bring in Dr. Anant Bhan, because Dr. Bhan, I believe you are one of those, and a part of the group that actually wrote a letter to the principal scientific advisor on this issue. Now, what were the concerns that you had? Because, I mean, I was also reading at the earlier advisories of the ICMR, which also didn't really openly advocate the use of plasma therapy.
Sure. Thanks, Tanvi, for having me. So yes, I was among those who had written a letter recently to the principal scientific advisor. And we had requested the science leadership in the country to look at the evidence, which was clearly not supportive of the utility of convalescent plasma therapy. We also highlighted the fact that a lot of patients and patients' families were actually running around and often, even if they were successful or not successful, feeling a lot of guilt about potentially the role convalescent plasma therapy could play in improving the conditions of patients with COVID-19. There have now been enough studies, including a large study which ICMR conducted, the PLACID trial, which was published late last year. There is a large study from the UK of almost 12,000 patients, and none of these studies clearly indicate any utility for convalescent plasma therapy, especially when evidence is gathered from high-quality randomized control trials. So given that, we felt it was important for our national guidelines, which were coming in from AIMS and ICMR, to clearly mention that there was no evidence of the utility of convalescent plasma therapy, because by leaving it out there, even as poor evidence or for off-label use, there was a chance that these therapies would continue to be used, and that we felt was not in the interest of patient benefit and also was causing a lot of confusion and perhaps misuse. And we are glad that the principal scientific advisor, the ICMR DG, and the director of AIMS have revised the guidelines, obviously working with the scientists involved in developing this guidance document. We are also hopeful that there are some other elements within the guidance document referring to hydroxychloroquine and ivermectin, where again the evidence is almost not there. And we are hopeful that those elements would also be addressed, along with this new epidemic of steam inhalation that we are seeing across states, which again there is no evidence for and might actually be harmful. So again, we are hopeful that guidance document continues to evolve and that it is very much focused on what the evidence tells us and does not leave any room for misinterpretation or misuse of what is in there.
In fact, let me ask that question to Dr. Aparna Mukherjee as well before I go on to our other panelists. Dr. Mukherjee, was this also one of the trigger reasons for you to, officially get it out of the advisory list itself, because of what we're seeing happen on a very large scale, frankly? People being harassed or being asked for obscenely high amount of money, the amount of trauma and, and pain and struggle that families were going through, running around asking for, some plasma donor to be available because they were told by the doctor that you need a plasma donor, and so go and get one. That's the only way to save your loved one. Did the scale of these instances push you to finally make this announcement, and could we have done it sooner?
Yes, even we are aware that there's been a very widespread use of plasma, or everybody's social media is flooded with, calls and queries of plasma. And so, that is what we we realize that people are using it very indiscriminately and not judiciously. As I said, that if you say that this is the way to save a patient is critically ill and this is the only way to save life, it does not really hold true. And if you are pressurizing, if the family thinks that, yes, this is the only way that to save, and that really puts a lot of pressure, particularly when it is not really having any therapeutic benefit. And so this is a living document, the guidance. It is updated now and then as and when evidence comes in, discussions are done, and so this updation was done. Even before, as you said, the guidelines never actually advocated such widespread use of plasma, indiscriminate of at what stage the patient is, what titers the plasma are, but it was still being done. So that's why it was totally removed, so that people don't misunderstand the guidance. And yes, each patient is the medical fraternity thinks again and then decides what to do.
So let me ask you, and then this question as well, that the IMA seems to suggest that no, it is helpful when it comes to moderate cases. Now, is this a classic difference between the researchers and those who are actually practicing it on ground? Because at the end of the day, it is the doctors who are going to be advocating treatment, diagnosing and deciding the treatment on the ground.
Yes, it is always the prerogative of the treating physician. His or her discretion is definitely the most important thing when an individual patient is being treated, because each case is different. So he or she might utilize their own expertise, their knowledge, and what they feel and read is good for the patient. What our role is, we collect evidence, generate evidence, and we can churn through that evidence and give a guideline, give a recommendation that, yes, this is what Indians and across the world, the scientific community is thinking. This is what the studies have found. And then these guidances can be brought out. So this is just to recommend to the physicians. But of course, the ultimate decision to treat is of the physician.
Okay, Dr. Bhan, where do you stand on the way IMA has responded to this?
So, of course, clinical discretion is important, and the physician is the final arbiter of what a patient needs to be receiving at a particular time in their illness. That having been said, globally we recognize the importance of not looking at anecdotal evidence, which is to say that I used plasma in a particular patient and I saw some benefit, but looking at the evidence which is generated by large studies, especially randomized control trials. We've had a fairly good study done in India by ICMR, as I mentioned earlier, and it clearly indicates that in Indian patients, in real world, in conditions which are very similar to real world conditions, where patients did not benefit from convalescent plasma therapy. And we are hopeful, just in the same way, scientists who have come up with this guidance document at ICMR and AIMS have revisited their decision to include it in the guidance document. IMA will also look at the evidence and then clearly understand that there is nothing which indicates a benefit for convalescent plasma therapy, and also not hence promote its usage.
Okay, Dr. Mishra, good evening to you. Would you want to weigh in on this, plasma therapy as an option? Very clear decision coming in from the ICMR, where the IMA seems to be taking a different stand. And, I'm just speaking from a common man's point of view. Because then I would be even more confused as to what to do. Should I spend all my energy and my money and my efforts to try and find a plasma donor to save my loved one's life or to help that person get better, or should I not?
I think, as you heard the experts explaining, the revised guidelines based on the evidence, and evidence not from one study to a large number of randomized trial that has been conducted, and there is no evidence that it is of any use. There may be some exceptional or some exceptions to this, but we can't make rule based on exceptions. So my take at this time is that so much of work has gone in. It's a new study. Lots of things are dynamic. We are understanding it. But one thing is clear that plasma of recovered person is not of much use. So at least people should not feel guilty that we didn't find a plasma, or we should not pressurize, although it has not been made illegal. So as you just heard, if a clinician thinks in certain specialized conditions, they can still do it. But this is up to the clinician. But as far as the scientific understanding of this aspect of handling these diseases, that it is of no real benefit in the real world. So we should not put expenses or feel bad or run for this, which is not of going to be much use.
Okay, fair enough. So that's as far as plasma therapy is concerned. And I think we've got the experts putting it out there as is what we know. One must always keep this in mind that the COVID infection itself, the virus itself, is still about a year and a half old. And there are more and more studies across the world being conducted, more trials being conducted, studies being carried out. The virus is also evolving. Our knowledge about it is also constantly growing. So sometimes there will be these changes. First, in this case, perhaps we could have been a little bit more clearer about it in advance. But it seems even now, irrespective of the ICMR survey, some doctors may have a different view on ground and decide how they want to go about treating their patients. But let's go to the second big talking point. There are four that we're going to address. Plasma was one. Then there is vaccine doses and the intervals that should be there. Then we will also talk about black fungus and what we know and how it's becoming a bigger concern, and the use of remdesivir and other drugs. So I want to talk about the vaccine dose gap. And Dr. Mishra, I want to start off with you. For AstraZeneca, Serum Institute, Covishield, we have now extended it to 12 weeks, to 16 weeks. And interestingly, on the day we did that, UK has actually narrowed the gap to 8 weeks to 12 weeks. Now, obviously, again, an example of perhaps more and more data that we are looking at. But what should the people right now, be considering? Should 12 weeks be the optimum time basis the data that we have?
Correct. That's what the decision to go for 12 weeks to 16 weeks is based on the information that we get largely from the UK, where this vaccine is used maximum. And there, like any other vaccine earlier, we thought is a 4 to 6 week. But then later, based on some unusual ways, it turned out that to 12 week is much more effective, which means the effect of first dose is more pronounced if the second dose is given around 12 weeks. But even in the phase 3 trial of this vaccine in the UK, there was also evidence emerging that those who were given after 12 weeks, not maybe up to 16 weeks precisely, these are the numbers 12 weeks, 16 weeks, they are put based on certain assumptions. It is not that a first dose or effect of a vaccine switches off on a particular date and switches on a particular day. These are gradual process. But general understanding based on reasonable amount of information is that if you give some second dose after 12 weeks or before 16, it will give good protection. That doesn't mean that if you give before 12 weeks, it will not give any protection. And UK took this decision to reduce the time because of the emergence of new variants. They wanted people to finish up this thing. And I don't think we have to. That is also based on assumption that before 12 week will be anything better than after 12 week. So I think that is something they are in different position. The purpose of the vaccine is to save life, and that involves what is our availability, what is our size, what is our efficiency, and where we stand. And I think considering all these factors, 12 to 16 week is a good choice at this moment, and we should not worry about too much about it. This is what Covishield. Covaxin doesn't change anything. It remains 4 to 6 week, and will go that way.
Okay. Dr. Anandvan, your view on this? Because, I mean, of course, there are multiple factors, better efficacy being one of them. Also, you know, what is your priority or your policy? Is it to at least ensure that more and more people get their first dose at least, and so you keep a longer gap and give one first dose to more people, or you say, okay, let's fully protect those who are vulnerable and give them the 2 doses before we move on to, to the others. Or like it is in UK's case now, they're looking at more and more variants and they just want to get everybody vaccinated quickly, so they've reduced the timeline.
Yeah, so Tanvi, it is, it's not unique to India that these kind of decisions have had to be made. This happened in the UK, it's also happened in Canada where the gap was increased. And often it's a pragmatic decision based on looking at the evidence around efficacy and also looking at what kind of stocks you have. And if you have a shortage, then you see if there is an option of increasing the dose. In India's case, we have 2 vaccines, one of which there is an evidence that a slightly longer dosing gap between the 2 doses could in fact be okay and it would still be fairly efficacious. And so if that helps us increase the number of first doses given out, it might be a good decision which is grounded in science. The only challenge, I guess, is that a lot of people probably are concerned that since they got vaccines, especially the older age group with a shorter dosing gap, whether that means that they have lower efficacy, etc. So I think that kind of public communication is important to clarify to them that they don't need to worry and the efficacy was still quite fairly decent and they would be protected. We also will need to at some point of time to look at the UK decision in light of the new variant, etc., because they've looked at, their concern has been the new variant and its spread. And we know that the evidence around Covishield was generated quite a few months ago. So we have to look at real world effectiveness data, which is coming in now, and also look at our own data collection to see if there are any concerns around efficacy as the vaccine is being rolled out, and then keep revisiting our guidance again. So I think as much as it is driven by data, it is important, but I'm not too worried about the increase in the dosing gap between 12 to 16 weeks, except for the need for public communication so that any fears around it are allayed.
Okay, fair enough. Let me address the other part here, which is about what if you've been infected? Then what do you do, Dr. Bhan? Let's start with you and then we will take it to the others. Earlier, we were being told that, you should wait 2 to 4 weeks. There was some suggestion, and our reporters found it from their sources that the National Technical Advisory was actually recommending a 6 months gap. And while that's not been officially accepted and advised by the government, on ground we're already picking up reports that that's what people are being advised to do, that their own doctors are advising them that, wait for 6 months before you get your vaccine shot. So what should it be? There's just a lot of confusion.
Yeah, I think there is probably, at least to my knowledge, perhaps a lack of clarity in the evidence. We certainly know that if you have had an infection, you should not be taking the jab immediately. There should be a gap. But how long that gap should be, there is, I think, varying opinions on that, and hence I would also be very keen on looking at what is the background or what is the evidence base on which the decision around 6 months has been taken. A lot of senior experts, I think, have indicated somewhere between 4 to 8 weeks as being the upper limit. If up to 6 months, there is some evidence to indicate that there is a degree of protection offered by recent exposure to infection, then I think that evidence should also be put out there. It's very important, I think, for guidance documents and decisions such as this to be substantiated by data and evidence. A good note which explains the background and the rationale for based on evidence would always help clarify what is the basis for the decision. Again, because otherwise a lot of confusion could arise. So I think this is one area where certainly we need more clarity around the evidence base behind the decision around 6 months or longer.
Okay, so for me to try and simplify this for our viewers as well, Dr. Mishra, of course, a lot of this the decision on when should you get your vaccine shot if you've contracted COVID already once depends on what information we have available on how long the antibodies continue to be in our system. And thereby after that, when will you need additional vaccine shot to make you able to fight this virus. In such a scenario, do you still believe that the evidence that we have suggests that maybe 2 to 4 weeks is still the ideal time gap, or can we actually extend it?
So these are things which depend on many factors. So 2 to 4 weeks is the minimum time. Before that, you should not take because it will be not of much effect. Vaccine is something similar to like natural infection. It's just that vaccine is safe. You will not fall sick except very small side effects. And natural infection can lead to more difficulties. But once you recover, you are something like vaccinated. So minimum 2 to 4 weeks is required. But how long you can wait is something, there are many ways of looking at it. So my suggestion will be that several months, up to 4 5 months, 6 months will be okay, because but if you can take before you do it, but you can wait, because we are not seeing lots of reinfection during first wave or even the second wave, which means that people, once they've got infected for several months, they are being protected because of their natural immunity that they've acquired. So that means even the new variants are not there. We see breakthrough infection, but we don't see so much of reinfection. I mean, there will be certain question whether we have enough data, whether first round infection was properly and thoroughly recorded, all those things. But having said all those things, we really think that reinfection is very rare, which means if you get infected and you recover, for a few months you are actually protected. So if you delay your vaccination by a few months, at least you should give it 2 to 4 weeks. But after that, if you get a chance, you do it. Otherwise, you can wait for a few months and this will be okay. So these are all, as you just said, pragmatic and practical decisions. There is no specific mathematics in this that after 4 weeks you will have this much percent, after 6 weeks you have that much percent. I think is acceptable that we can wait up to 2 months after you have recovered and you will be reasonably well off. Particularly in a situation where there are others who need this, and to save life, we want to spread as much as possible, because the pandemic is not individual disease. As long as any certain number of people are infected, we are all susceptible. So best is to break the chain and reduce the number by covering the vaccine as much as possible. So looking from that angle, anything which does not compromise the individual, at the same time covers larger section of society, should be a preferred strategy, and we should support that and accept that.
Okay, let me also say good evening to Dr. Chandrakant Leria joining us right now. Dr. Leria, the question that I'm asking, and we are discussing with our experts right now, is how long should a person wait after they have infected and then recovered from COVID to get their vaccination shot?
Tanvi, for inviting me. So we know that there are different set of guidelines, and Government of India till now say it's a 4 to 8 weeks gap after the recovery. The World Health Organization say that a person can wait for up to 6 months. The background of this recommendation is that we know that after natural infection, it has been found that nearly 80% of the people are protected or do not develop infection up to the age of up to the 7 months of gap. So that rationale can be used that a person can wait up to 6 months. However, we also need to be mindful that there are new strains which are emerging, and since protection is limited, but we also need to keep in mind that even after vaccination, the protection is 80%. So we know after natural infection, 80% protection is provided for 6 months. After vaccination, 80% protection provided for some period of time. And so summary point is that vaccination programs are always a combination of technical and operational feasibility. So I think it is time that the decision to increase the gap between after recovery and the vaccination is increased. And currently it's 4 to 8 weeks as per Government of India guidelines.
So you're saying it is time to increase it up to 6 months, and that should be an all right policy to put in place?
In my opinion, yes, that will be the right policy. because vaccination programs are always technical guidance and operational feasibility. And we know that it's equally important in India to deliver at least one shot of the vaccine to the people who need it and who had not developed the infection in the past. The people who already has developed infection and recovered are already protected. So use of limited vaccine, which is an operational point in this case, for the people who need it more, will be the right approach. And that approach will be waiting for 6 months, in my opinion. And that's what WHO also recommends.
Okay. So I'm going to, come back to this point in just a bit, but we have a couple of our viewers who are also waiting on the phone line with their comments and queries. Rishi Divedi is on the phone line calling us from Mumbai. Good evening. What would you like to ask? Okay, we're just gonna check if Rishi is still online. Meanwhile, let me see if Mr. Rajiv Khanna can hear me. Good evening, Mr. Khanna, calling us from Delhi. What would you like to ask?
Yeah, hi, and thanks. I had COVID in November. Good evening, ma'am. Thanks. I got an antibody test in December.
You will have to mute your television, said Rajiv Khanna, and then speak to us because you will get your own voice with a lag and that will not allow you to finish your point. So I suggest you mute your television set and then speak to me. I can hear you. Go ahead, please.
Thanks. Okay, so I had COVID in November and I was hospitalized. I came out of it and I got my antibody test in December. It was a 128. And I got my antibody test about 2 weeks ago. It was 240. Should I have a vaccine test, and will the vaccine wipe out my natural antibodies, which may be better?
Okay, thank you so much for calling. Dr. Leria, would you want to take this one? Here's a viewer who says got COVID in November and then recovered. As of 2 weeks ago, his antibodies stood at 240. What should he do?
I'm not sure what is the reference value in this one. Usually the reference value is 1 or less than 1 or higher. But this number, I'm not sure and how it has increased over a period of time. But I would suggest that since current recommendation is that wait for 4 to 8 weeks, but operational approach is 6 months, and you are approaching nearly 6 months, you can consider getting vaccinated again.
Okay, so either which ways, because you're almost at the end of your 6 months since you got infected, you can consider getting vaccinated now is the advice that's coming in. Thank you for calling in, Mr. Rajiv Khanna. Let me also say good evening to Dr. N.K. Arora. And Dr. Arora, the conversation right now we're having is the gap you should give after you recover from COVID and you get your next vaccination dose, whether it's the first dose or the second dose. And while officially the government hasn't changed the timeline, there is a recommendation to make it 6 months. Many on ground are actually already advising this to their patients. Now, there is a concern though there, Dr. Arora. The concern being that are we, pushing the timeline and the gap a little too much because of the current situation that we are in, where we don't have enough vaccines and we would want everybody to at least get one shot?
So, taking clue from what Mr. Khanna from Bangalore was telling us, he has very good antibodies even now. Now, first thing, his concern was that if I take a shot now, will it suppress my natural immunity? The answer to that is, in fact, vaccine will act as a booster, and all those who have a previous episode of COVID infection, and when they take a vaccine, first dose itself, you get a very good response, and second dose is further. So, in fact, post-COVID infection, your immune response becomes much stronger vis-a-vis those who have not been infected. Number two, your question that this whole issue of deferment of the vaccination after somebody has a lab positive corona infection. This is based on science that, as Mr. Khanna was also telling us, that most of the people have persistence of antibodies. There are several studies globally which say that the antibodies may persist between 6 months to 9 months after an infection. There is an Indian study also which is suggesting that antibodies do persist. The whole programmatic decision has to be and will be that the risk of reinfection between the time when person has completely recovered and person goes in for the first dose of vaccine, it should not expose the person to a susceptible period when reinfection can occur. So rightly, as you are suggesting that we should be very careful that the person should not unnecessarily. So initially we had kept 4 to 8 weeks. A revisit to the decision is being done. Final decision is going to come in next few days. The second issue is that it is a vaccine sparing strategy. There is no doubt about it. That vaccine, but with a science behind it. Because if I, instead of 4 to 8 weeks, if I say, okay, 8 to 12 weeks or 12 to 24 weeks, depending on whatever the final decision comes, that in that case, what you are doing is you are using the natural immunity of that person to continue to the pool of overall community, immune pool of the community, and then giving at the right point so that reinfection must not and should not occur. So these are all considerations that is being kept, that we get herd immunity as soon as possible, but the person is not kept susceptible or exposed susceptible to get a reinfection. Does it help to understand the philosophy behind it?
Okay, fair enough. That's the view as far as our experts are concerned when it comes to the vaccination doses gap between when you get infected and you recover and when can you get your vaccination shot. Let me just, Mr. Arora, since you've joined us right now, let me also ask you on the other change that's recently taken place where we've extended the gap between the Covishield first dose and the second dose, and the concern that many people have there is, why are we increasing it when in other countries like United Kingdom they're actually reducing the gap?
That's a I was expecting this question, and that's excellent question. First of all, we do not blindly follow whatever the others are doing. We are following science. When in January we started, all of us were told that why don't you start with 12 weeks because UK is doing it at 12 weeks. But we were not convinced, and there was Indian data. 6 weeks later, we revisited. There was some additional data, but we said we will keep it at 6 to 8 weeks between, but we were not convinced about 8 to 12 weeks because of breakthrough infection. And then recently, in last week of April, the real life data from UK has come. Now here I would like to modify you that everywhere else in the world people are using. There are only 2 countries in the world which are using almost 95-97% of Covishield or AstraZeneca vaccine, UK and India. There is no other country in Europe is using it. Even North America as well as Canada, they have stockpiled the vaccine, but they are not using it. Very small amount is being used in Latin America, and nothing much to say about Africa. So what I'm trying to say is that India and UK are the prime consumers. UK went back to 8 weeks in a shorter interval, then they will have a better protection or higher antibody level because they are afraid of 617, the Indian mutant. While we have learned with the Indian with the UK data, because we are not facing only 617, but in North India, for example, 117, the UK variant is as prevalent as 617. And therefore, we feel in our context that this 12 to 16 weeks is the one which will provide the best protection to our community. The next thing is that we have also established now, in the light of these anecdotal experiences, that a lot of people are getting breakthrough infections after one dose, after two doses also, and some of them getting serious disease also. So a national vaccine tracking platform is being established, which will be done over next 1 or 2 weeks, so that on an ongoing basis, we are monitoring any breakthrough infections, the impact of this increased interval between two Covishield doses, and also if any new kind of variants are emerging out of it, of the overall vaccination program. So that kind of a comprehensive platform is in the process of being established. But I must assure you that decisions are being made for the context, the epidemiology, and the best interest of our people.
Okay, thank you so much for clarifying on that as well. Now, if I may move on to one other aspect, and also take a couple of viewers on the phone line. Rishi Dwivedi is back with us. He was calling us from Mumbai. Good evening. What's your query?
Good evening, madam. My question is that hello.
Yes, go ahead, please.
My question is that my wife got first dose in first week of April, and today we called the vaccination center. They said that come after your call after 84 days. So we understand that the gap has been increased. But suppose after 84 days the situation doesn't improve or the vaccines are not available, whether we can switch the vaccine, because by that time some new vaccines might also be available, like Sputnik or maybe Pfizer or some other brand might come in the market. So after some time, can we switch the vaccine, or we have to go by the Covishield only second dose after 84 days? Because we are not sure that after 84 days she will get the appointment or not for vaccination.
Okay, I think Mr. Dwivedi, you should definitely hope that we will have more Covishields by then, and as has been made very clear by the government right now, that the priority has to be given to those who will be eligible for their second dose. Governments have been told to keep a separate 70% of the allocation for the second dose eligible, so that they don't miss their window at all, even the extended window. But because of a larger point that you raised, let me ask, Dr. Daria, do you want to comment on this? Is there an option that people have of switching to another one in case, the vaccine, the brand that they got first, isn't easily available in the market at that point?
So he has two set of questions. First, that what happens if the vaccine is not available at the 84 days? So the first point is that though this is a recommended window of 12 to 16 weeks, but if there is a delay beyond this window, person can take vaccine as and when available. So there is no upper bound unless it goes, let's say 1 year or later. But if it's not available at 12 to 16 weeks, as early as after that, person can get vaccinated, which could be 3 months, 4 months. So there is no harm. The first shot which is administered will always be counted, no matter what is the gap between the second and first shot. The key is that ideally it should be taken, or optimally it should be given at 12 to 16 weeks. But after that, as and when the vaccine is available, and we hope that it will be available on time, but in case it is not available, take when the same vaccine is available. That brings me to the second question. Till now, these vaccines have not been studied for interchangeability, which means the person who has started with a particular vaccine had to take the same vaccine for his or her second shot. However, there are some studies going on different parts of the world, and maybe after a few weeks or a few months, details or findings from those studies might be available, and then we might be able to say a little with more confidence whether vaccines can be interchanged. But as of now, it cannot be interchanged. To summarize, take
Okay.
vaccine when available, same vaccine when it's available. Changing the vaccine is not allowed as of now.
Okay. Let me go across to Mr. Pushpendra Tripathi, who's calling us from Aligarh with a query. Good evening, Mr. Tripathi. Go ahead, please.
Good evening. About plasma therapy, I mean, in the beginning of the show that you people were discussing, but I would say, I mean, madam, that nothing concrete research has been done so far. Earlier, it has been said, okay, that it is useful in order to treat the COVID-19, but now they say, okay, that it's not useful. I mean, so what kind of this permutations and combination is going on? I mean, this is all trial basis for a human being. My second query is that about the steroid. Steroid, I mean, to take this one is a patient's choice or a doctor prescribed him. If doctor prescribed, I mean, they should literate firstly, na? I mean, that if doctor prescribed, then what patients would do? I mean, patients is in a dilemma. I mean, so they should get trained. I mean, when it is useful to give the steroids,
Yes.
the people are not literate. I mean, in this level, I mean, they cannot go for this steroid. They do not know about the meaning of steroid.
Yeah, you're absolutely right there.
Yeah. And the third one is
Absolutely
why the time
right there,
period
Mr.
has been
Tripathi. In
extended,
fact,
madam.
that's the point that we've also repeatedly raised here. Yes, that, the people will not know. You and I are going to go as per what our doctors tell us. If they tell us go get remdesivir, we will go get it. If they tell us get on to steroids and consume these many steroids on a daily basis, we will do it, even if we are in home isolation without any need for hospitalization. So how do you tackle that scenario where the doctors are prescribing it? Dr. Bhatt, would you like to take both of these queries, again, one on the plasma therapy of what is the evidence available, if you want to, simplify and explain it to our viewer again, and of course on steroids as well.
Sure. So, as we know, it's been a learning pathway over the last more than a year of trying to understand what works for treating COVID-19 and what does not. And there was some early evidence from relatively poor quality observational studies, etc., which seemed to indicate that there was a role for convalescent plasma therapy. Perhaps that's how it got traction. But then, good quality studies, randomized control trials, both conducted in India and abroad, have systematically shown that there is no utility for convalescent plasma therapy. And hence we are at a situation now where most international bodies, as well as the new guidance document from ICMR and AIMS, is very clear in saying that convalescent plasma therapy has no role to play. And I think that is what the message should be going out to both practitioners, medical professionals, as well as to the lay public, so that we remove the hype around plasma therapy. We do not focus on it anymore. We don't amplify requests for plasma therapy. In fact, we discourage them. And we focus on medications or interventions which work. Now, steroids are an example of interventions which work. There is evidence towards it. These are also relatively easily available. But there is a problem with steroid usage, which is that it needs to be done very strictly under medical supervision, and that we need to be careful, especially in patients who might also have non-communicable disease, whose sugar levels might be high, because we do know with steroid usage, your immunity might go down, your sugar levels might shoot up, and then you might be susceptible to infections like mucormycosis, commonly called as black fungus. So I think that's where the importance of stewardship, ensuring that there is medical supervision, is important. Anything which could be misused, anything which could be overused, anything where there could be a side effect which could also be a cause for concern, obviously needs to be very clearly looked at. So if people end up popping steroids at home, in home isolation, without really understanding some of these potential side effects, then that could be a cause for worry. If someone is admitted and these side effects are not kept in mind by medical professionals who are treating him or her, that's a cause for worry. So I think more education directed at both patients as well as practitioners is important, and that is where I think the role of discussions also is crucial, so that we are better informed in the way we imbibe information both as professionals as well as patients.
Yes, you're absolutely right there. And, since we've come to the conversation topic of steroids and how excess use of steroids can also lead to conditions like mucormycosis, a quick question on that to Dr. Rakesh Mishra. Dr. Mishra, Suddenly now again, from a common man's point of view, we're just hearing so much conversation about this black fungus and how more and more cases are coming in. New advisories are being done. Now better tracking systems are being put into place. Can you shed some more light on this as to how do we now tackle this challenge?
So this black fungus is something which is a new factor in this process, and this is and there are some interventions for that. But it's something very new. But its connection, why it happens in these patients, what is the source of this, whether it's oxygen pipeline or something else comes, it's not really my domain of expertise. And I think Dr. Bhan or Dr. Lahoria can put more light on this.
Dr. Laria, would you want to come in on this?
Yeah, sure. So we know that in the recent, the second wave, we have seen many cases of black fungus or mucormycetes infection. These infections have been found and noted in those people who either have some underlying disease condition, especially diabetes, but who were on the steroid or who had some other immunocompromised disease condition, immunocompromised condition. So in these patients, some of the infections which are related to eyes or nose, especially those are infection due to fungus in the sinuses which have been reported. And once the person is affected, and since person was on steroid, the immune system of that individual is not able to respond to this. And in that situation, the condition become really worsen, and especially it might affect the eyes. So unless this situation is identified in the timely manner, and unless treatment is started, his condition can worsen and it can be really dangerous. Some of the key signs of this is black funguses are that there is a swelling and redness around the eyes and nose, but along with that, person can still have a fever, headache, there can be difficulty in the breathing. So common symptoms of which we see in the COVID-19, along with that, if a person see a redness around and swelling around the nose and eyes, that should be a cause of concern and should be investigated by the treating physician. Of course, we know that some of the treatment is available for this condition. So key is to identify the situation early and start on the treatment.
Yes, to identify it early and to start early on treatment, and I think also to spread more and more awareness to amongst people as well as to when they are getting prescribed steroids, if those are the conditions under which it is required, because there are far too many instances that we're also seeing where people are in home isolation, not even requiring hospitalization, but have been put on steroids, and which is a bit of an overstretch. My last question, or last topic rather, Dr. Arora, is on remdesivir. Now, while repeatedly experts advising the government and otherwise in our country have specified when it has to be used, under what conditions it has to be used. In the latest clinical guidance that has also been put out by ICMR, it very specifically tells you the conditions when it should be prescribed. Yet, overprescription of this drug and overuse of this drug continues. Now, how do we tackle this situation? Surely a common man can't be expected to turn around and tell the doctor, no, I don't think this is the right way to go.
So the situation is very much like plasma therapy, which was mentioned just now, and remdesivir. We know that WHO and some of the other internationally accepted bodies have not recommended remdesivir because various studies are showing that although it is an antiviral drug, but it has very limited value in terms of duration of hospitalization. When you look at the data, it does make a minor difference in terms of mortality, but the studies which are available, the numbers were less. Now, question is that whenever doctor prescribes and the drug is not available, it creates a kind of anxiety on the care providers and also a feeling of guilt that I have not done the best. But the fact of the matter is that today the true therapy for coronavirus is paracetamol in the first phase when you have fever and a flu-like illness. In the second phase, when the disease becomes moderate to severe, when you become hypoxic, when there is a problem with breathing and there are other manifestations of intense inflammation or a kind of a storm going on in the body, the steroid is the only other thing, and some supportive in terms of anticoagulants and some of the other supportive. Even antibiotics, rampant antibiotic usage is not recommended. So, coming back to this whole issue of remdesivir, it is of limited value. Only the physician should decide that there might be some benefit. Please do not, I would request the audience and the viewers that many times doctors are pressurized to prescribe things, both plasma as well as remdesivir, when it may not be truly required. They have limited, remdesivir particularly had very limited value. And I think beyond that, it's not a magic drug. It does not, in a transformative manner, changes the outcome of a sick or a severely ill corona patient.
Okay, thank you so much for explaining that, once again, and I hope that helps our viewers as well. And I'm afraid I'm completely out of time, but like always, it was a pleasure to have all of you on this conversation and taking up our doubts and queries when it comes to all things COVID, from plasma therapy to remdesivir and other drugs, to black fungus and the overuse of steroids, and of course vaccination and the gap between the vaccine doses. Those are the things we addressed today. If you think there are other aspects of COVID treatment that you have queries about, then do write to us or tweet to us, and we will definitely try and line it up next time with our experts. Thank you so much for joining us on the Urban Debate.